Good morning, and thank you for joining us today. Thank you for the introduction, Janice. So during my time at Lynn, I've had the opportunity to participate in the Family Navigator program, and I came in at a time when the program was just getting ready to start a pilot to assist families receiving a diagnosis here at the Mind Institute. This program is really valuable, and research has shown that families face many barriers to receiving services after a diagnosis of an NDD. Lack of information about neurodevelopmental disorders often can delay the start of treatment. And we've also found that feedback from clinicians has come out that have said that during the short time that they have with these patients, they really don't have time to delve into all of the community resources and different treatment options that are available. So the Family Navigator team wanted to really take a look at what we felt were some of the key barriers to treatment and things that we could tackle as volunteers in the program to really help families work through. Some of the key barriers are cost, knowledge of resources of treatment, navigating the system, and at times stigma with the community, with sharing a diagnosis with a family. It can really have long delays or just prevent families altogether from receiving treatment for a neurodevelopmental disorder. Recognizing the need to support families, the Family Navigator program was tasked with identifying these barriers to accessing services after receiving a new diagnosis, identifying the resources available for impacted families, especially in the Northern California, Sacramento area, because that's where most of our families do live. And also to develop a process for the volunteers in the program, because Family Navigator does have a few staff members that dedicate some of their time here, but it's also really volunteer driven. And all of the volunteers in the program and the staff members do have a family member that's been impacted by a disability in some way. So really having this group of volunteers that have had an opportunity to navigate the system has been very valuable to the program. So starting with the pilot, at the beginning of January, we asked clinicians to start recruiting families that had a new autism diagnosis. The pilot's going to run through June, and our goal is to be able to have peer-to-peer support of 12 families with this new diagnosis. Here's a sample form of the referral to the Family Navigator program that the clinicians fill out. So after a diagnosis, families are asked by the provider if they have any interest in participating in this program. Some basic information is gathered, along with preliminary information on resources that the family is interested in. The team also receives a copy of the full report from the clinician. And we go through this report to answer any questions that the family could have on resources that their clinician is recommending. And we do want to make sure that people understand that we are not clinicians. We let our families know this all the time. If there are any clinical questions, we do ask them to go back to the provider to receive that information. So we're not delving into getting into their diagnosis and answering any clinical questions. As you researchers know, with any good program, it's important to measure success. So we decided that we would have a survey at the beginning of their participation with peer coaching to measure their knowledge of programs, their plan to access services, and the program's role in services that they receive. So we're going to ask them some questions, some baseline questions at the beginning, ask them some questions at the end of the program to see if Family Navigator does indeed help them through their initial time with an autism diagnosis. So this is an example of the experience a family could go through in Family Navigator. They have a clinic visit and an initial diagnosis. We receive a clinician referral. And some of the resources that we might touch on in Family Navigator could be referring to the Family Resource Center. Here in our area, it's called Warmline. Helping them navigate some of the education system if they have questions on how do I request an IEP? What do I do if my child has a 504 and I want it to change over to an IEP? We often do refer people to contact the regional center if they're not already engaged. An important reason with the regional center engagement is if you do have insurance and you ever have a lapse in that insurance, the Regional Center can do things like help you navigate through getting a Medi-Cal waiver, so your child always has that as a backup secondary insurance. The Regional Center provides a lot of great tools that families don't often know about, some toileting assistance supplies. They'll provide medical ID bracelets, so the Regional Center is a very important referral. And then sometimes we want to make sure that the families are doing something to still just have fun, just be a normal kid, be a normal family, so we might refer them to, there's the Challenger Sports Program, there's Special Olympics. We might make a community referral out to a local sports program. And then the program doesn't really have a clear end for the families. If they want to come back at any time or re-engage, ask a follow-up question, they're welcome to participate in Family Navigator in the future. One important part is really establishing community partnerships, not just telling people about the programs, but reaching out to different organizations in our community to gather materials that we could give to families, different collateral, to really know about training opportunities, about seminars that are in the area. So we're trying to establish, we have a great relationship with Warmline, with the Regional Center, of course with the existing Mind the Gap program that's here at the Mind Institute and at different universities. They've been helpful in guiding us and giving us some information on tools that they are developing. Community members and different focus groups and community professionals learning more about what we can provide to families along the way. They're really often overwhelmed at the beginning of the diagnosis, so establishing partnerships is important because we want to make a warm handoff whenever possible. We'd like to know if they want to be engaged with the local family resource center like Warmline. We call Warmline or send an email and say, we have this family, do you have someone that could contact them and go over some of your programs? So making that warm transition really takes some pressure off the families. It's one less phone call that they might have to make. And as you can imagine, the services and resources for people of all ages with autism and other neurodevelopmental disorders is quite expansive. So we're working on building a concise toolkit that we can refer families to. One focus that I would like to take on is to provide a website, an online resource for families that could be updated either through the Family Navigator team, or we could ask Warmline to provide us a link to their event. So anytime their website is updated, the Family Navigator toolkit automatically would be updated, because some families do like to receive hard copies, but some families also like to receive things online. So after our pilot, our goal is to have the Family Navigator program available to all families receiving a diagnosis at the Mind Institute. Right now for the pilot, we really were focusing on autism diagnosis, and as of May 7th, we had 12 families that were active in the program. We have other families on the wait list, but we're waiting to receive their full clinical reports before we reach out to them. And we think that this program will really help families increase their knowledge of their diagnosis, and in turn help the providers here, give them some support in knowing that they won't have to spend some of their valuable clinic time trying to print off or gather all of these resources. We want to be the go-to place that clinicians here at the Mind Institute can send families to, along with our existing resource center and the SED. And I want to thank the Family Navigator team, especially the people here at the Mind Institute that are part of the team: Kathy McKitka, Erin Roseborough, and Maribel Hernandez, Dr. Robin Hansen, who oversees the program, my mentor, Dr. Megan Miller, and also thank my fellow LEND trainees and the other mentors in the LEND program. It's been great working with you, and I really appreciate the opportunity to be part of Family Navigator and LEND. So thank you. And if you have any questions about the program, let me know.
Hi everyone. Today I'm going to be talking about a program that I started working on at the beginning of my fellowship in 2016 with Dr. Pakurak, and it's focused on trying to improve collaborative care and multimodal treatment for ADHD here at UC Davis. And so I'm going to give a brief overview about multimodal treatment for ADHD and what that means, and talk a little bit about some of the challenges of delivering multimodal treatment in primary care settings and just in our health system in general. And I'm going to talk a little bit about this program, a pilot project that we're doing to try to help really address some of the challenges and try to improve access to multimodal treatments for patients and their families. And so in terms of multimodal treatment for ADHD, dating back to 1999, the NIH and the US Department of Education co-funded a study looking at which treatments were the most effective for ADHD. And they studied almost 600 children with ADHD between the ages of 7 and 9. And they randomized them to 3 different groups: medication management only, behavioral treatment only, and combined treatment. And they compared that to community care as usual. And in terms of the behavioral or the psychosocial treatments, it was a fairly robust program. It included parent education groups, individual parent training. Those same parent educators would then also be consultants for the teachers. The students would go to a summer camp where they were learning social skills and other things that could be helpful for them. And then the same aides in the summer camp were then aides in their classrooms. So it was a really well thought out behavioral approach for ADHD. And then what they found was that if you looked only at the core symptoms of ADHD as measured by a behavioral rating scale, they didn't see a huge difference between medication only and the combined treatment group, which was a little bit of a surprise. But actually, if you look at broader outcomes in terms of looking at comorbid anxiety, parent-child relationships, parents feeling like they're effective in sort of engaging with their children and being able to set limits, longer-term academic outcomes, and really the things I think that contribute to better functioning for children, then the combined treatment was superior really to medication only. And there's been a number of studies that have followed these kids. This was an older study, but these children have been followed out in a naturalistic way over the past 15 years since the study ended, and they're collecting data on them. Even though the interventions themselves ended after 14 months, they've followed them along to see what kind of difference this intervention has made. And we think that the longitudinal outcomes are better for the combined treatment group. So this leads us kind of to this concept of multimodal treatment for ADHD, and really thinking about our treatment as involving lots of different areas. And I think, the columns on your right, I think, are important for all kids with ADHD, and then I think medications are important for some. And so, in terms of medication options, we've got stimulant and non-stimulant-based medications. In terms of school-based supports, things like student study team meetings, 504 plans, IEPs, working with a school counselor if there's any kind of social difficulties or challenges going on, options for social skills groups, and then more for kind of behavioral therapies, parent support and education groups, some options for parent coaching, ADHD coaches that may help kids, particularly when they get older, about how to get organized around their schoolwork, tutors, and then cognitive behavioral therapy. And really the CBT for younger kids has been found to be more effective for comorbid conditions like anxiety and depression, not so much for the core features of ADHD, but as people enter like young adulthood and they're able to sort of think more about their own thinking, CBT actually can be a primary treatment for core symptoms of ADHD. And also complementary treatments like exercise. There's some, in nutritional supplements, there's some evidence for omega-3 fatty acids to help with cognitive functioning. And the thing I realized that's missing from this is sort of the upcoming research in technology, and sort of I think that's still emerging, and are there certain ways that technology and even the virtual reality program that's happening here could offer some additional methods for treatment. So in terms of thinking about how do we implement this in our current healthcare system and within primary care in particular, and we're focused on primary care because that's where the majority of kids with ADHD are diagnosed and treated. It's a fairly common, the prevalence is between, I think, 5 to 7% and can vary depending on the study. But in looking at primary care settings, what are the barriers to trying to implement programs like this? And Dr. Leslie and colleagues down in San Diego looked at a program to provide support to primary care providers to implement the American Academy of Pediatrics recommendations for ADHD evaluation. And they had things like an ADHD coordinator, and they provided resources for the providers to give to families, and then they asked the primary care doctors, what did you think of this program? What were the barriers? And they said that sort of difficulty collecting information from schools, difficulty recognizing and treating coexisting mental health conditions, problems accessing behavioral therapy, difficulty providing resources and education to families, and time constraints. And even though this is a bit of an older study, I think these things really hold true for a lot of providers, and particularly in primary care. And so this brings us to this pilot project that we've done. It's been Dr. Pakurak in the Department of Psychiatry and myself, and then in conjunction with the Primary Care Network, and then Health Management and Education, have collaborated to develop a program to try to improve access to multimodal treatments and improve awareness of the importance of multimodal treatments in ADHD. And I think also to try to increase collaboration between primary care and kind of children's behavioral health. And so in terms of how the program is set up, there's 3 components. The first component involves a 3-part educational series where Dr. Pakurak and I went to the primary care office, and we had 3 separate days, and they were separated by about a month to give people some time to digest the information. And we talked about multimodal treatments for ADHD and really tried to spend about equal time talking about the 4 components that I had listed, and really focusing on what are these other psychosocial supports that can be helpful in addition to medications. And then the second component was that Dr. Deborah Fishman, through the Health Education Department, she offered a parent support and education group locally at the primary care site. So that way primary care doctors could refer the families directly to their own site to have a parent support group. It was 3 sessions, so it wasn't actually like an ongoing group. It was more of a way to get information to families. And we also talked about other options in the community, including the ADHD Parent Support Group here at the Mind Institute, chad.org resources, and then options for doing groups virtually online. And then the third component is ongoing consultation, where the primary care doctors can reach back out to us to ask questions about their cases, or we can talk about whether or not a referral to child psychiatry makes sense. And so in terms of program outcomes, what I did is we did a kind of like a survey after the 3 educational sessions to see how helpful this information was to the primary care doctors. And generally what we found is that people reported that they felt they had improved knowledge about ADHD, multimodal treatment for ADHD, improved familiarity with school-based supports, increased likelihood of referring parents to a parent education group, and that they felt like they had more contact with child psychiatry. This is just kind of a representation of the survey data, and it was just a Likert scale that I did, and the bars on your far right are sort of strongly agree, and there were a few not applicable if people missed particular sessions, but it seems like people felt like the most helpful thing for them was the information about parent support groups, the educational resources, and then opportunities for collaboration. And then in terms of, I think there's a lot of opportunities for improvement and sort of, I think, making changes or sort of growing out this program to include some additional things. I think the providers reported frequently that increased access to parent support groups and community resources were really important, and that was an area that I think we would potentially need to try to offer more resources. And then similarly, behavioral therapy and parent coaching, a lot of the emails that I've received from providers after have been sort of describing certain circumstances with a given family and what sorts of resources would you recommend by way of therapy for the family. And I think that's definitely an area of need that providers are struggling with. And then I think further opportunities for collaboration between primary care and child psychiatry, in terms of, there's lots of other models for collaborative care in terms of building things out with a care manager and having a child psychiatrist co-located with primary care That's much more robust than this program, but I think there's good data to support that type of collaboration. And I think increased interdisciplinary collaboration, which has been something that I've greatly valued through the LEND program, and I think it would have been really helpful to have, for example, a special education teacher at our talk on 504 plans and IEPs, and I think that would have made the discussion much more rich for the primary care providers. Potentially having kind of families involved along the way in the discussions too. So lots of areas for improvement. Thank you for your time and allowing me to present. Yeah.
Hi, so as you said, I'm Suzanne Shimoyama. I'm one of the Child and Adolescent Psychiatry Fellows here. And I'm going to be talking to you today about my literature review looking at electronic media use in children and adolescents with autism. Research into patterns of media use in children and adolescents and the associated risks and benefits is an emerging topic of study. The pattern of increasing media use is fairly well established in the general population. This figure is taken from Common Sense Media's 2013 0 to 8 report and shows an increase in the use of mobile media among young children between 2011 and 2013. Patterns of teen media use are also striking. A Pew Research Center report from 2015 showed that 92% of teens go online daily, more than half of teens go online several times a day, and a quarter report being online almost constantly. While teens have described benefits to feeling plugged in, including the sense of feeling more connected to friends, there are also several well-studied risks associated with excessive media use. The odds of being overweight are almost 5 times greater for adolescents who watch more than 5 hours of TV compared to those who watch 0 to 2. There's also evidence that early TV habits may have long-lasting effects. 2 studies found that excessive TV viewing in childhood predicts obesity risk well into adulthood and midlife. Excessive electronic media use is also associated with not getting adequate sleep. Lack of sleep may affect mood, schoolwork, family life, and social life. Internet gaming disorder, it's a DSM-5 condition in need of further research. Essentially, it's similar in pathophysiology to other types of addictive disorders with both symptoms of withdrawal and tolerance. And there's also a similar dopamine release in the striatum and nucleus accumbens and a downregulation of postsynaptic dopamine receptors. Studies show that up to 8.5% of youth ages 8 to 18 years old might meet criteria for internet gaming disorder. Depression. Research shows a U-shaped relationship between internet use and depression, interestingly, with increased risk at both the high and low ends of internet use among teens. The American Academy of Pediatrics released guidelines for media use in 2016. So some of these recommendations include placing limits on hours per day and types of media used, promoting the recommended amount of daily physical activity, 1 hour, and adequate sleep, 8 to 12 hours depending on the age of the child. Recommend that children do not sleep with devices in their rooms and avoid screen exposure 1 hour prior to bedtime. Discourage entertainment media while doing homework. Some of these sound kind of obvious. Designating media-free times together and media-free locations in the home. So, while all children clearly may be affected by the ubiquitous nature of electronic media in modern society, researchers, parents, and clinicians have anecdotally observed that children with ASD may have a special affinity for electronic media. Therefore, it would be important to know if this is true, and if so, does it put these kids at additional risk for health or behavioral problems? Conversely, could there be some benefit in engaging these children using this type of a platform as a tool? So I conducted a PubMed search looking at recent peer-reviewed articles that featured the relationship of children and adolescents with ASD to electronic media. What I found was that the 23 papers I included separated into 3 general categories: descriptive, risks or problems, and beneficial uses. The papers I categorized as descriptive studies all surveyed either children, their parents, children with ASD, their parents, or both. Some of the earlier and often cited studies by researchers like Kuo and Mazurek appeared to show a pattern of increased non-social media use amongst kids with ASD, particularly with video games and TV use. However, Most of these studies were relatively small and often without nationally representative samples or matched controls. A much larger study was conducted by Montez in 2016 using data from the National Survey of Children's Health from 2011 and 2012. The ASD subpopulation for this study had 1,393 subjects, and the comparison group of children without ASD had 64,163 subjects. Contrary to the previous studies, Montez found that no statistical differences between the ASD and non-ASD groups existed for screen media use. The second category of studies focused on potential problems associated with electronic media use, the first of which is obesity. Children and adolescents with ASD have a higher rate of obesity than their typically developing peers. Several small studies found associations between obesity and increased screen time with this population. A systematic review by Jones and colleagues in 2017 looked at studies focusing on physical activity, sedentary behavior, and their correlates with children with ASD. It showed that although estimates of time spent in each activity varied between studies, children with ASD tended to spend more time using electronic media and in sedentary behavior and less time in physical activity than typically developing peers. Supporting the idea that children with ASD have more difficulty getting the recommended 60 minutes of moderate to vigorous physical activity per day, a separate study found that parents of children with ASD reported more barriers to accessing physical activity than typically developing kids. Some of the barriers they discovered were an increased, greater need for supervision in children with ASD by their parents, and problems with exclusion by typically developing peers. Individuals with ASD are high risk for sleep-related problems. In multiple studies, Engelhardt, Mazurek, and colleagues have looked at electronic media use in sleep in children and adolescents with ASD. These studies showed mixed results when looking at whether the presence of media in the bedroom was associated with shortened sleep duration. It appeared that those who used screen media as part of their bedtime routine, specifically, showed significantly greater sleep onset latency than those who did not. However, the mere presence of electronic media in the bedroom was not associated with sleep-related problems. Separately, time spent playing video games was found to be uniquely associated with less sleep among boys with ASD. A third area of concern identified by recent studies is problematic behavior in video games. Multiple studies have found significantly greater levels of problematic video game use in children with ASD than typically developing kids. These problems included getting angry when interrupted from games or playing longer than intended. Earlier studies looking at the general population showed that lower social competence and greater impulsivity predicted the number of pathological gaming symptoms experienced by an individual. This finding suggests that children with ASD might be at increased risk for problematic video game use, given that a core feature of ASD is deficit in social communication and social interaction. Engelhardt and Mazurek found that in-room access to a video game console predicted oppositional behavior while controlling for access to other media devices. However, parental rules appeared to be the mitigating factor in this. Only children with no rules regarding their video game use showed the elevated risk for oppositional behavior with in-room access to video games. The most recent paper I identified for this literature review was just published in April of 2018 and synthesized most of the topics I'd hoped to cover in my lit review, so they beat me to it. In their comprehensive look at electronic screen media use in children with ASD, Gwinnett and colleagues created an updated set of recommendations for media use. These recommendations may piggyback on the existing AAP guidelines I briefly touched on earlier and are problem-based. If we look at the first example on the left, we see a common problem many of our parents face: increased use and difficulty disengaging from electronic media. These recommendations include setting an automatic timer on devices that shut off after the time limit is exceeded, having transition reminders, and having consistent daily times for media use. Other recommendations include using media guidelines for the child's developmental age rather than their chronological age, and using media to reward participation in physical and social activities. They caution against using electronic media as a pacifier, as it encourages tantrums when the device is removed, and rather using it in limited doses as a reward for good behavior and relying on other coping strategies for de-escalation. It's also important to carefully monitor your child's media use for bullying, exploitation, and inappropriate behavior. Now that we've touched on some of the potential harms of screen media use, let's switch our focus to some of the positive applications. Technology, including assistive communication devices, have been used to help children with ASD learn for several decades. A meta-analysis by Greenspan and colleagues in 2014, looking at studies of technology-based interventions for children with ASD, showed evidence for the overall effectiveness of technology-based training. These studies included interventions such as virtual reality, computer-based facial recognition programs, and TeachTown software. Other recent papers show promising technology-based interventions for children with autism, including social media to improve friendship quality, video modeling to teach activities of daily living skills and increase variation in play, mobile platforms that allow for enhanced delivery of in-home therapeutic interventions, and a children's television show to model behaviors. Robots are also being employed as potential therapeutic tools to enhance social skills and communication. Although most of the papers I reviewed touted potential benefits of technology-based interventions, one recent randomized controlled trial by Fletcher Watson and colleagues in 2016 showed no significant group differences when using an iPad intervention for social communication skills in preschoolers. Shout out to the mind. I just wanted to point out some of the important studies looking at innovative interventions using technology here at the Mind, the Screen and Leap studies, and the virtual reality study that I think is concluded now. So what can we take away from this literature review? First, more research is warranted in this area, ideally with larger sample sizes and higher powered studies. In the meantime, it would make sense to use the AAP guidelines as a starting point and potentially layering on the recommendations discussed earlier specific to children with ASD as appropriate. It's really important to remember that children with ASD are a heterogeneous group, and while it's important to understand generalized risks and benefits, it's important to tailor the recommendations to the specific child's needs. Finally, it would be great to continue exploring and critically examining the effectiveness of promising technology-based interventions. Thank you for your attention. I'd be happy to answer any questions.
Thank you for that introduction. So this is actually part of my dissertation, and I thought it was really interesting, and it's a special place in my heart for this topic. So to begin, the significance of this topic. So the reason why I thought it was really important is because of the mental health aspect of it. Because of the fact that children in general who have no friends they have a higher risk of mental health issues, specifically depression and feelings of loneliness. Already children on the spectrum feel lonely and feel isolated because of their differences. So that's one of the reasons why I thought it was really important. Also, to individuals who lack a friend are at an increased risk of victimization, so basically bullying. So the impact of friendship. So based off of preliminary research, they have found that there are actually positive influences of friendship on individuals with ASD, especially in 3 specific areas. So in cognition, there's an enhancement of perspective taking. There's also enhancement of representational thoughts, which are also areas that are very difficult for children on the spectrum. The social component, they saw that there was a reduction in the severity of the social and communication impairments. So it wasn't a complete elimination of the social deficits, but it decreased the severity of those symptoms. Also, too, there was an increase in play and shared enjoyment. As for language, there was also an increase in their receptive, which is the understanding of language, as well as the expressive component. So already, friendship has been shown to be very influential. So with this LEND project, I did an interview. I actually did 9 interviews with experts in the field from various disciplines who have extensive knowledge within autism and within friendship based off of their experience working with this population. My experts included this list, and I asked them all standard questions because I wanted to see kind of what their inputs were based off of the standard questions. Some of the questions included what makes friendship in the ASD community similar to and different from their neurotypical peers. How might culture influence friendship, development, and maintenance in the ASD community? How impactful has technology been on friendship development and maintenance within the ASD community? And another question that I had was, how might we professionals better promote friendship within the ASD community? Because I thought that those questions, in addition to other ones that I asked, were really important because then it kind of gives more of a holistic view of this topic. So based off of the interviews I did, I transcribed them, as well as I conducted qualitative analysis, which is basically, I did an inductive form of this analysis, where I looked for themes. I had independent reviewers code for the themes, so I did my own analysis of it, and then I had independent reviewers look at it and also kind of develop their themes based off of the data. And then from there, we came back together and we had our little meetings where we just kind of went through what our themes were, and we found consensus on pretty much all the themes that we saw. As well as I did member checking. So basically I have done 2 presentations based off of my dissertation, and then from that I discussed it with professionals as well as individuals within the field of autism to see kind of like, are some of the information I'm providing what you've seen in your practice or your daily life? And so it was really interesting to see kind of the similarities from that. And so my results. So the themes that I discovered was that children on the spectrum, they really do have a drive for friendship. There is a motivation there. The issue is these social communication deficits as well as the repetitive and restrictive behaviors, because those greatly impact their ability to actually apply what their drive is into action. There's the influence of culture, so based off their culture, it really impacts what their view of friendship and how even their families think about friendship. Technology, which is key because we live in a world where we have our smartphones and we go on the computer, and so that is really important, as well as the implications. So the significance, the results from the interviews about friendship in the ASD community revealed that, like I mentioned before, there's a desire and motivation for the friendship. There's very much a uniqueness to friendships in the ASD community. While with them, there might not be quite that great depth to it, but still there's that friendship there. There's that relationship in which they can connect with somebody and actually practice some of those skills that we spoke about before, like the cognition, also to helping them with their language, and also practicing kind of the social skills. The influence of culture on the relationship. Within the interviews, it was really interesting to hear about how some of these professionals, their experience working with families of children who have autism, and the fact that some of them, based off of their culture, their desire for treatment was very different. So one mentioned that based off of her experience working within the Asian culture, a lot of the focus is more on academics and not so much on the social component. And so it's kind of understanding that, while another professional discussed how in like more of the Hispanic community, it was more about friendship within the family system, and it wasn't so much outside. So it was really interesting to kind of hear the differences in how culture can really impact the drive for friendship. And then the next one is the pros and cons of technology. So the pro is that it can really help to kind of buffer some of the social deficits, because then you have Facebook or social media where they're given enough time to process what they want to say and put it in. So it gives them that buffer. But there's also cons, because there's harm with going online, especially when you're very naive, and you don't understand kind of what certain sites are. And then they also said that there's a need for better empirically based multidisciplinary programs. A lot of the social skills programs out now are based off a Western perspective. And so for those that are within collectivistic culture, it doesn't really take into consideration it's not about the single person, like in an individualistic culture. It's more about the family and how we all support each other, how the whole community supports each other. So understanding that and including that into the programs. With that, there were also differences within the interviews that I conducted. And so one of the things is with culture, do we include the child's cultural values and treatments, or do we focus solely on the Western perspective? Based off of, like, right now, we're living in the United States where it's basically a Western perspective. So do we just focus treatments on that and just help them enhance that part? Or do we kind of go with the cultural values of the individual where it's the collectivistic perspective? The other thing is technology. So it's really interesting, based off of kind of the interviews, how each one of the professionals use technology in a varying perspective. So some use it in the middle where it helps to kind of engage the treatment. There was one who said she does not use it because it's very distracting to treatment, while there's another one who actually developed her own video game to help with the social skills component. So it's very interesting to kind of hear how within the fields, the various fields, they use technology in various ways. As well as the last one is treatment. So when it comes to targeting kind of the social skills component, which is involved in friendship, some believe that we should focus on specific social skills one at a time, while there's others who think that we should use all those skills in order to enhance the engagement, the social engagement. So not just focus on one, focus on a bunch of things at one time to make it more naturalistic. So the application of findings. So based off all of the interviews I did, as well as the analysis and then checking, the things I found important were the need for collaboration between the various disciplines, as well as including the input from the ASD community. Because at the same time, while collaboration with the various disciplines are important, because then you're kind of on the same page and everyone's working together as a team, if we don't have the input from the community, it wouldn't really make a benefit to them because we have to hear what they would like. The second one is increase in multidisciplinary, culturally sensitive interventions. More technological programs, but ones that are kind of, that help with those specific components of friendship development. And then awareness and psychoeducation is definitely needed. As for my future, I hope to use this information to continue sharing it with individuals, professionals, even the lay community, to disseminate it and hopefully publish it. And that's the end of it. Any questions?
So as this audience knows pretty well, youth with autism spectrum disorder are a growing population with immense healthcare and mental health needs. The latest CDC estimates place the prevalence of autism at 1 in 59 children. Schools are the main service provider for children with autism, with special education enrollment quadrupling since 2004. Despite the existence of evidence-based interventions, there remains a large research to practice gap with limited implementation of these interventions, especially to fidelity in the community. Special education teachers report using interventions with little empirical support at higher frequency, even despite knowledge of better practices. Therefore, it is critical to work with community providers in order to bridge this gap between research and practice. It is a priority for the National Institute of Mental Health to reduce mental health disparities in effective treatment by racial and ethnic groups, geographical settings, and socioeconomic status. And this is particularly important for children with autism. However, there are a number of barriers to effective services for minority and low SES students with ASD. Even though, as can be seen from this map, many states serve a large percentage of minority students, most intervention research has been conducted with homogeneous, primarily Caucasian high SES samples. In addition, minority children receive ASD-specific treatment services much later than white children, receive fewer services, and are less likely to receive high-quality evidence-based care. Therefore, to improve services for these students who are in the most need of extra support, we need to understand the ways in which the implementation of evidence-based practices differs for practitioners working with minority groups. Therefore, the aim of my project were to investigate whether districts that serve more traditionally underserved students, so less students who are Caucasian, more students living in poverty, more students receiving free and reduced price lunch, more Hispanic Latino students, and more students who are Hispanic Latino and have autism, whether or not those districts have worse classroom quality and intervention fidelity when learning a new evidence-based intervention. So this project was based on data collected as part of a randomized control trial evaluating classroom pivotal response teaching. CPRT was adapted from pivotal response teaching, which is a naturalistic developmental behavioral intervention, and was adapted by Aubin Stamer and her colleagues in order to help teachers deliver PRT in classroom settings, as opposed to the one-on-one traditional approach that it was developed as and used in clinical settings. So 17 school districts across San Diego County were recruited and enrolled 109 teachers to participate across this 4-year study to receive training in CPRT. And those teachers in turn recruited students. Each teacher selected 2 students each year to participate, so that's why it's a little bit more than double the number of teachers depending on what year the teacher was enrolled. So my project focuses on the 103 teachers who we had classroom quality data available for the year which they received CPRT training. The majority were female, Caucasian, had a master's degree, and had been teaching students for autism for almost 10 years. The classroom type that they taught in varied based on teacher report, but the large majority of teachers had classes categorized as serving children with mild to moderate or moderate to severe disabilities. To assess classroom quality and the use of recommended practices for students with autism, the adapted version of the Professional Development Assessment was used, which was originally developed by the Professional Development in Autism Center at the University of Washington, and then was further adapted at UNC as a measure of usual care. The assessment has 3 components: a 2 to 3 hour classroom observation, an IEP review for at least 2 students with ASD in the classroom, and a teacher interview to gain additional information. All of the PDAs in the current study were completed by master's level individuals with experience in classroom settings and expertise in autism. The assessor then takes the information from all of these sources and rates on 58 different indicators from minimal implementation to full implementation, and then those indicators are kind of placed on 7 different domains. I'll be focusing on kind of the 5 of the primary domains: classroom structure, which looks at the use of schedules of activities, how students are expected to spend their time, and the use of data collection by teachers; classroom environment, which includes factors like the teacher-to-student ratio, use of strengths-based instruction, and the type of learning opportunities the teacher provides; curriculum and instruction, which examines the types of goals that are being addressed and the feedback that students receive; social and peer relationships, which looks at how the teacher is providing support to students when interacting with peers and kind of the types of opportunities students have to interact with peers; the management of challenging behavior, which looks at the tools that teachers have in place to prevent and address difficult behavior, as well as a total school that involved all of these domains. When looking at fidelity around CPRT use, video observations of teachers were collected 4 times annually and behaviorally coded to assess fidelity of implementation of CPRT strategies. So we looked at overall fidelity, as well as teachers' use of antecedent motivation strategies. So these are strategies like incorporating choices, following student interest, and incorporating preferred materials and activities into the lesson. Facilitating responding strategies, which includes motivational strategies, as well as strategies to gain the student's attention, providing clear cues, and taking turns with the student. Consequence strategies, such as providing direct reinforcement and reinforcing the student for trying or at least attempting. And teacher preparedness strategies, so using motivated materials and activities, managing distractions when providing a lesson, maintaining control of the lesson and of the classroom, and varying the instructions and the prompts given to the student. District demographic characteristics, so the percent of white students in the district, the percent of Hispanic Latino students in the district, the percent of students who are Hispanic Latino and had autism, the percent of the students in the district living in poverty, and the percent of free and reduced price lunch students were drawn from publicly available data sets from the California Department of Education, as well as the census. Generalized estimating equations were used to examine the association between district demographic characteristics and classroom quality indicators. Generalized estimate equations were used to account for teachers that were nested within districts. Just to note, all the kind of variables were measured continuously, so as kind of one goes up, the other one is also increased, or if it's negative, one is going down while the other one is increasing. And to note for the next two slides, arrows that are in green indicate a significant association, while those in orange indicate an association at a marginal level, so significance. So none of the district demographics were associated with classroom structure. However, in districts that served a larger percentage of white students, they had better classroom environment, while those that served a larger percent of Hispanic Latino students had a worse classroom environment. Around curriculum and instruction, the white districts that served more white students had better curriculum and instruction, while those that served more students who were Hispanic Latino and had autism had worse use of curriculum and instruction strategies. Around social and peer relationships, districts that served more students living in poverty used kind of worse social and peer relationship strategies around supporting the social and peer relationships between students in the classroom. All the district demographics were associated with the management of challenging behavior in the expected direction. So districts with more white students had better management of challenging behavior, while those with more minority or low SES students had worse management of challenging behaviors. In regards to overall classroom quality, the districts that served more white students had better classroom quality, while those that served more Hispanic Latino students or more students living in poverty had worse overall classroom quality. When it came to looking at teachers' CPRT fidelity, there were no associations with the overall fidelity to CPRT strategies, but districts that served more students who are Hispanic Latino and had autism had worse use of those antecedent motivation strategies, worse use of the facilitating responding strategies, no difference for the use of consequence strategies, and when it came to teacher preparedness, the districts that served more white students had better teacher preparedness, while those that served more Hispanic Latino students with autism had worse teacher preparedness. So in conclusion, this data at least gives preliminary support to the idea that districts that have more kind of high poverty or high minority youth have worse classroom quality and worse fidelity when implementing a new evidence-based intervention, although it varied depending on the district indicators. There are a number of limitations to note when thinking about these results. First of all, this study was conducted in San Diego, and so the largest racial and ethnic minority population there is Hispanic Latino, and therefore doesn't represent the range of minority students or generalize beyond the district served. In addition, different district demographics were pulled from publicly available databases, so it doesn't speak to the demographics of the students in the particular classroom. It's really looking at more of kind of the context of being in a school that is serving a high percentage of minority or students with low SES. This study also doesn't really address why this might be the case. It could be that it's more stressful to work in a high poverty, high minority district. There might be fewer resources, less leadership support, because the management of challenging behaviors seem to be consistent across all the indicators. It may be that if you're working in a classroom where you're having a really hard time managing challenging behaviors, it's then especially harder to then learn a new intervention on top of it. And lastly, I also didn't look at student outcomes. The hope is that better classroom quality and better CPRT fidelity would be associated with better student outcomes, but that's not something I was able to look at here. But as a next step to address some of these limitations, we're currently involved in a multi-site randomized control trial across Sacramento, Los Angeles, and San Diego called the TEAM studies, which is looking at enhancements to our training for CPRT, both at the leadership level and the teacher level, to improve leadership support and teacher motivation when learning a new intervention. And we're currently working on a disparity supplement that's due next month as a way to try to figure out ways that we can first get at the why. So, is it stress? Is it management of challenging behaviors? Is it teacher burnout? Is it, leadership report or lack of resources that might contribute to lower, high poverty, high minority districts having worse classroom quality and worse fidelity? And if we can, both through quantitative and qualitative data collection, kind of get to that question of why, can we develop enhancements in order to improve the services in these settings that really, are the kids who need this help the most. So I'd like to thank the children, families, teachers that all participated in the CPRT study, the U.S. Department of Education for funding the primary randomized control trial, and the UCSD and Kazarac CPRT team who conducted the initial research. Thank you.
Thank you very much for that introduction, Janice. As Janice mentioned, my project will be developed in about 3 years, so I still have to get data and information. I wanted to start by giving some kind of background information about why I think this is a really important project. So in 2015, there were about 5,000 live births in California. Of those, well, actually, this is 2015. I'm sorry, I was not able to find the 2016 live birth. But 8.5% were preterm births. And of those, breakdown by race and ethnicity, we can see that the majority of the prenatal are Black and American Indian or Hispanics. And then only 7.7 was white. This is really important, as you see that little baby hand. We have in California, we have California Children's Services, and that is a state program for children with certain diseases or health issues. And they have established a California Children's Services High Infant Risk Follow-Up program, and it's to identify those children that come out from the NICU and may have diseases or health issues that may have them qualify for CCS services. So they have established, they paid some of the NICUs to have their clinic follow-ups and screen for those developmental services or any other services that they may qualify for. The NICUs that don't have that program, they have to have like a collaboration with someone that does provide those services. So this is a really convoluted slide. I don't expect anyone to know that. But it's really important for us to know that if a baby is born with less than 32 weeks, or it's tiny that only weighs about 3 pounds, they immediately qualify for this clinic, for those type of services. Also, if you were born at term or but have some seizures at time of delivery, if you had some heart issues, if you had some lung issues, if you need oxygen, things like that, you will also qualify for those type of evaluations and services. And it's really important to know that although we know that some NICU babies, or graduates as we call them, are at risk for neurodevelopmental disabilities or developmental delays, not all of them are being referred or followed up after NICU. It's also important to know that families of low income or low SES are less likely to be have access to those type of services. So what do we do in a high-risk infant follow-up clinic? we have 3 main visits, and that has to be before age 3. So they have to be evaluated not only medically, but we have also to track their development. We have to make sure that they have a family has like some type of psychological support if they need it. And then we are also in charge of coordinating care for them once they need services. So not only services for therapies or things like that, but also medical services like do they need hearing tests, do they need eye exams, what do they need? We are there to help them. So the IDEA, the Individuals with Disability Education Act. So Part C of that, what it's intended to enhance and develop the development of infants and toddlers with disabilities, and to minimize the need of them for special education and to maximize their potential for independent living. In California, Part C, it's delivered through the regional center, which is, they are contracted from the Department of Developmental Services. So if we see here, this is from extracted from the Department of Developmental Services. So the majority of consumers, so about 39% of the population, it's Hispanic. And then we have the other breakdown we see there. Whites, 32%, and then the Asian, it's about 7%. Despite Hispanic being the biggest majority population of the regional center, they have the lowest regional center purchase per capita. So that means that they are not receiving as much as other ethnicities are. It's like 8,000 versus 18,000 in whites. So the objective of my study, of my project, is to identify patterns in early intervention referral rates by race, ethnicities, and socioeconomic status. Identify the percentage of individuals receiving those services after we refer them for services. And how am I going to do that? So CPQCC, the California Perinatal Quality Care Collaborative, has combined efforts with CCS, and they maintain a statewide population-based data set with the hopes to facilitate quality improvement opportunities and to reduce long-term morbidity in babies after a NICU stay. So for my project, it will be a secondary data analysis from that big database that they have. And eligible patients will be those that early interventions referrals were needed in the first visit, second visits. So why I think this study is so important? First of all, personal, I'm Hispanic, as you can get. I don't know if you get it from my accent, but I am not happy with disparities. I get like upset, like personally upset when I see disparities to Hispanics. I feel very, I feel it personal. So this study is meant to identify disparities in referrals and the receipts in early intervention and services in California based on their race and ethnicity once they come out from the NICU. And hopefully, we can explore the potential barriers to accessing those services. Also, hopefully, we'll be able to promote systems that are able to support better care for underserved population. And with that, spark more research to make policy changes, what we need to make sure that they have what they need.